So I'm going to talk about emerging approaches for bifurcations. Well, yeah, no, I know that. By the way, guys, this logo, I'm not sure about this. I'm available to discuss it further during the coffee break. Anyway, so my career has been focused for many, many years on arguing why one stent would be better than two. And so now, finally, I've got to the point where, having more or less proved that adequately to my satisfaction anyway, maybe it's time to prove that no stent is better than one. And, this has been a labor of love. It's been stents, how to expand them, how to optimize them, where to cross the struts, lots of arguments about proximal, mid, distal, how to deform them and then reshape them, how to use fewer stents. Yes, an entire career of this. And, we've done 20 years worth of papers, one step better than two, one step better than two, one step better than two, blah, blah, blah. And now we go to, is no stent the best option of all? So the beauty of DCB bifurcations is that none of this complex stuff is now needed. You place two wires, you never move them. Once you've got your two wires down, you're secure. You never got to jail one of them, then try and recross, fail to recross, etc. You're home. You have two wires. You never need another one. No risk of passing behind a stent. No recrossing. No OCT to check whether you've crossed distally, etc., etc. No jailed wire. So this is basically what's happened for me. Is that an entire career's work has now just gone up in smoke. But I'm not bitter. I'm happy. This is progress. So basically, DCB really simplifies bifurcation PCI in those respects. Most of the complexities are removed. That's not to say that it's straightforward. You have to take a bit more care over every step than perhaps you did with stents, but it's essentially two wires, a few balloons, finish. And that's how you do bifurcations. It's quite brief. But of course, it does complicate the process because you have to use your brain as you go. Instead of just having a plan A, B, C, D, you have to assess the result at every stage. So I've done pre-dilatation with a non-compliant balloon. Okay, is that good? Or do I now need a scoring or cutting balloon? Look at it in a couple of views, work out what's happening. Yeah, it's okay. Probably need a scoring balloon, cutting balloon, etc. Do I need to do that in both branches? Probably. Etc., etc. So you have to use your brain and think at each stage, what's the next step? And actually, that doesn't suit everybody. Some people much prefer to have a recipe. It's A, B, C, D, and then I'm finished. So this won't necessarily suit everybody. But doing it with drug-coated balloons makes it sort of appropriately complex rather than a simple recipe. And you have to have sequential attention to detail. And actually, there have been many, many trials over the years, right the way back 2007, if you look at the PubMed sort of citations for bifurcations and drug-coated balloons. But nearly all of them have focused on the side branch and have not quite had the, well, I don't know if courage is the right word, but have not decided to focus on the entire bifurcation. And of course, that's a tough ask if you're trying to design a study when the MACE related to the side branch is low. Right from the start, the Nordic 1 study, the MACE rate was so low, and very little of it was actually related to the bifurcation, the side branch of the bifurcation. So it's a tough ask. How do we actually do these? This is a sort of, well, typical-ish example, sort of subtotally occluded LAD. So two wires. Start off by treating the main vessel. This is a particularly simple case, by the way, as it turns out. Having decided that you're happy with what you've done in the main vessel, it's opened up, there's no recoil, there's TIMI3 flow, there's no dye hold up in that vessel, then you can treat the side vessel similarly, one-to-one, not necessarily the highest inflation pressures, maybe a scoring or cutting, it's up to you. Then, once you're happy that you've got an adequate result in the side branch as well, TIMI3 flow, no hold up of dye, no spiral dissection. You then do the reverse, which is drug-coated balloon 1-to-1 low pressure to the side vessel, and then finally drug-coated balloon 1-to-1 to the main vessel. So it's main side, side main, straightforward. And in this case, it looks like this. It never looks like this, and so it was quite worrying actually. Because it's like, oh, that doesn't look right at all. It should have dissections and things visible in it. Anyway, sometimes, occasionally, it looks like this. I was a bit disconcerted, frankly, but that's how you do bifurcation. So, and you don't have any of the problems that you have with stents. So there's no wire wrap because you've only got your 2 wires. No wire jail. No need for a pot. No need for recrossing, no deforming, reforming, etc., etc. No IVUS, maybe, I'm to spare a few more minutes, unless you want to learn how the dissections subsequently behave. But much better attention to lesion preparation. We had become very lazy operators, you sort of a little bit of a predilatation, then bang in a big stent to high pressure and send for the next patient. It was, so this is going to make us better operators, I think, and actually we'll get better stent results as well from doing this. Of course, we've had one trial that I was a bit perplexed, I must say, by the difference here right at the start. Maybe it's because in this, which was predominantly focusing on the side vessel again, maybe it's because they actually had a 1-to-1 balloon there for a whole minute. And that has made a difference. I don't know if anybody has a really good explanation for the difference so early in this trial. I'll be interested to hear it. And so now we're doing a formal study. As you will know, the EBC-DCB study, lots of people in this room are participating. And this is going to look at the entire bifurcation, not just the side vessel. So the idea, of course, is to determine whether non-left main bifurcation disease treated by DCB is non-inferior to a provisional stent strategy. I won't go through this. You all know this. The design is that we'll have 750 patients, 8 countries, 20 sites. So it's relatively ambitious in that sense. It's a European study with the European arm of South Korea also participating. And it'll be any bifurcation in the non-STEMI setting. And it should be true bifurcations, basically needs 50% narrowing at the ostium and the side branch, and the side vessel itself needs to be 2.5 millimeters in diameter, or 73, funny number, 73 millimeters long. That's adapted from the SNU criteria. So this is entirely what you're used to with the bifurcation studies. I won't go through this in too much detail. This is sponsored by the Medtronic family of stents and drug-coated balloons. We're very grateful to them for that. And the primary endpoint is a bifurcation-related endpoint of bifurcation-related MI, bifurcation revascularization, etc., at 1 year. And because of the 2% year-on-year decrement that you get with stent failure, we are having follow-up going all the way out to 8 years. And you may not see the benefit completely early on. We may see it a bit later. We'll find out. I won't go through the detail of the strategy. It's really, as you've heard in the last day and a half of attention to detail. Of course, you can put a stent in if you need to. That's not crossover or bailout. That's just part of the strategy. If you happen to end up with dye hold-up, less than TIMI3 flow, or you have dissection propagation, then of course you can put a stent in. That's why it's so great. That's why, that's what differentiates us from the POBA era when this stuff was terrifying. It was bypass surgery if you had that. And my last slide here, just to congratulate Manuel Pan, who was here by Zoom at a meeting at 7 o'clock this morning, who's put in the first 5 patients into the study, and we look forward very much to you all participating and getting us a result about bifurcations. Thank you very much.